Good afternoon, everyone. It's a joy to meet you all once again in this platform. So, every month we have this case presentation sessions, and this month we are very happy to have Mr. Rahul here with us. So, Mr. Rahul is an accomplished optometrist with over 5 years of experience in clinical practice and 3 years in teaching. With a strong academic and research background, he has contributed significantly to the field of optometry, publishing more than 5 research papers in reputed national and international journals. Passionate about advancing eye care and knowledge sharing, he has actively guided students and participated in academic forums. His experience lies in bridging clinical excellence with innovative research, making valuable contributions to both patient care and optometric education. So, we are very privileged and honored to have Mr. Rahul here with us. And a student from his college is here to present. And after the presentation, Rahul will be sharing his clinical pearls. We welcome every participant to listen actively and post any questions in the chat box. And after the presentation is over, we will be opening the forum for questions as well. So today we have a case presentation on glaucoma, and let's sit back and enjoy some good academic inputs from this case presentation. So over to the presenter.
Good afternoon, everyone. A very warm welcome to all of you, and thank you for joining today's webinar. I am Gnanammal, and I'm currently pursuing Bachelor's in Optometry from the Institute of Management Study under McGill University. And I would like to thank the organizer for giving me this opportunity. Today, I will be presenting on the topic glaucoma, the silent thief of sight, which is also the leading cause of irreversible blindness worldwide. In the next few minutes, we will be looking at the basic anatomy of the eye, what is glaucoma, their types, their diagnosis, management plan, and a few case studies. So as we know, the human eye, which is almost about 2.5 centimeter in diameter, we have three coats of the eye, which is the outer protective layer, which consists of the cornea and the sclera. The cornea is a transparent front surface, and the cornea is the opaque surface of the eye. After that, we have the vascular layer, which is also known as the uveal tract, which consists of the choroid, ciliary body, and the iris. And the inner layer, which is the neural layer, consists of the retina, and it is the light sensitive layer which contains the photoreceptor cells like rods and cones, and from there only the signals get transmitted to the optic nerve. And the central retina is known as the macula, which is responsible for sharp central vision. And over there we have the optic disc, which is the blind spot of the eye. And this is the basic anatomy. And also we have the crystalline lens over here, which helps us to focus the light which enters the eye onto the retina. Apart from that, the eye can be broadly divided into anterior segment and posterior segment. In the posterior segment, we have the vitreous cavity, which contains the vitreous humor, which is a gel-like structure. And in the anterior segment, it can be again divided into anterior chamber and posterior chamber. The anterior chamber is the green part over here, which starts from the posterior surface of the cornea and the anterior surface of the iris, and the posterior chamber is from the posterior surface of the iris and the anterior surface of the crystalline lens. And the anterior segment contains the aqueous humor. So, as we saw that aqueous humor is present in the anterior segment of the eye, we have ciliary bodies which have ciliary epithelium which secretes aqueous humor, and it provides the structural support needed for the eye. The aqueous humor travels from the back of the iris, and then they go to the anterior part of the iris, and over there at the angle where the cornea and the iris meets, we have a trabecular meshwork. We have trabecular meshwork, which is a spongy thing which drains the aqueous humor, and from the trabecular meshwork it goes to the canal of Schlemm, and from there in the aqueous veins, and after that it moves forward to the episcleral venous system, and then it goes to the general circulation of the human body. So as we saw that there is a aqueous humor which is being produced. As it is being produced, it also needs to be drained at a specific time. So what if there is a drainage problem? If there is a drainage problem, then the intraocular pressure will increase and the fluids will exert pressure in the eyeball, which will eventually lead to optic nerve damage. And if the optic nerve gets damaged, then the signals won't reach the brain, and thus there will be problem in our vision perception. So, what is glaucoma? Glaucoma is actually a group of eye disorder which can cause vision loss and blindness by damaging a nerve which is at the back of our eye, and it is called the optic nerve. The symptoms can start so slowly that we may not actually notice them. And the only way to find out them that if we have glaucoma is to get a comprehensive dilated eye examination. As we can see, glaucoma is a group of progressive optic neuropathies, and it is characterized by optic nerve damage and visual field loss, which happens on the retina. And it's not always necessary that glaucoma needs to be associated with rise in IOP, but it can also occur if we have a normal intraocular pressure. So, the basic classification of glaucoma is primary, secondary, and congenital. Primary glaucoma can also be classified further as primary open angle glaucoma, primary angle closure glaucoma, and normal tension glaucoma. And the secondary glaucoma are those conditions in which glaucoma happens as a result of some other issues, like, for example, uveitis, traumas, or other things. And congenital glaucoma is the one in which glaucoma is present from their birth. It's inherited. And we will look on further classification of glaucoma. The first type, which is open angle glaucoma. As you can see, here is the cornea and the iris, and the angle over there is open, okay? But there are some clogging in the trabecular meshwork. Thus, thus the aqueous humor can't be drained properly. So what happens is the angle is open, but since there is problem in the drainage as there is clogging in the trabecular meshwork, what happens is the IOP gradually increases. And open angle glaucoma is one of the most common type of glaucoma. And initially, what happens is in the outer retinal rim of the retina, there's atrophy, and which leads to peripheral vision loss, and then eventually the optic nerve gets damaged, which leads to central vision loss. And as the pressure increases, some of the most common type, as it is this, what happens is it is a gradual process, it is painless, and it is most commonly bilateral, but there are also cases that a person can have unilateral open angle glaucoma. Some of the risk factors are if the person is above 40 years of age, or else they have a family history of open angle glaucoma, or if they are myopic, and if they have diabetes. So what are the clinical symptoms which we can see is there is a rise in IOP, and there is a change in optic disc, which is called optic disc cupping. We will look into it. And there is peripheral visual field loss, and it is often asymptomatic until late, as it is a slow process that increases gradually. So most of the time we don't get to notice that actually what is happening over here. And then next we have closed angle glaucoma. In closed angle glaucoma, as you can see, the angle becomes too small. So what happens is the aqueous humor can't actually flow from there. And as you can see, the lens is pushing against the iris, and there is no pathway for the aqueous humor to move over there. And the drainage is also get blocked. And closed angle glaucoma can also be termed as narrow angle glaucoma. When the angle is narrow, it is called narrow angle glaucoma. And if the angle gets totally closed, it's called closed angle glaucoma. And since there is blockage over here, the pressure gradually builds up, and then there is severe eye pain. And what happens since there is sudden rise in IOP in closed angle glaucoma due to the blockage, the person has severe eye pain, redness, blurry vision. They have headaches, nausea, and visual halos. And some of the common symptoms are this, and some of the signs are that the pupil are mid dilated, and they have corneal edema and conjunctival congestion. And closed angle glaucoma is one of the ophthalmic emergency. If a person is having closed angle glaucoma, we need to treat them as soon as possible. And we should not further wait for some other things. This is closed angle glaucoma. And then even if a person has a normal IOP, there are chances that they can get glaucoma. What happens? The real reason of normal tension glaucoma is not yet known, but some of the major contributing factors are risk factors are vascular dysregulation, low blood pressure, migraine, and ischemia. And it is often genetics, it is hereditary. And in normal tension glaucoma, the pressure remains normal, but there are some problems in the optic nerve. Thus, visual informations don't get properly delayed to the brain, and it is more common in Asian population and it needs regular diagnosis. So these are some of the most common types of glaucoma. And as we read, cupping of the optic disc, this is the normal cross-sectional image of the retina. As you can see, this is the optic cup, and this yellow thing over there, this is the optic disc. If we view it from the above side, this is the optic cup and this is the optic disc, and their ratio is always less than 0.5 in normal condition. But what happens as in cases of glaucoma, the IOP increases and gradually the optic cup begins to form a more cup-like shape. As you can see, it is a bit bent down, and the optic cup and optic disc ratio changes, and the ratio is greater than 0.5. And cupping of the optic disc is one of the most prominent sign of glaucoma. And over here, we have some of the visual defects which happen in glaucoma. At first, we have nasal step. In nasal step, you can see that there is a step-like formation in the visual field, and there's a temporal wedge, and there's established superior arcuate defect. It's an arc-like defect on the visual field, and over here, there is defect as a central 10 degree. And these are the different types of visual field defect. Over here, it is the end stage where there is complete loss of the visual field, and over here we have tunnel vision defect. And in this, there is a superior arcuate defect with peripheral breakthrough. And this is the superior fixation threatening paracentral defect. These are some of the most common visual field defects in cases of glaucoma. So what are the diagnoses? Some of the diagnoses which we can do is tonometry. In tonometry, we use an instrument known as tonometer, which measures the IOP of the eye. It can be done both in contact and non-contact way. In contact tonometer, what happens is we have a probe, a Goldman applanation tonometer. We have a probe which touches the front surface of the cornea, and then it measures the IOP of the eye. And in non-contact, we use puff of air, which is thrown on the cornea, and then it measures the corneal response. We also have gonioscopy, with which we evaluate the angle, and thus we can know whether the person is prone to close angle glaucoma or not. In fundus examination, we specifically focus on the optic disc cupping, and in visual field testing, we see how that person's visual field is. They have tunnel vision or arcuate scotomas. Over here, this is the normal report of the visual field test, and this is a person's report who has glaucoma. And one of the OCT report is displayed here. In OCT, with the help of OCT, we actually try to understand whether they have problem in the retinal nerve fiber layer. If there is thinning of that layer of the retina, these are some of the most common diagnoses which we use to detect glaucoma. And management are we have both medical and surgical management. In medical management, we use prostaglandin analog, which is latanoprost. It is the first line defense which we use for managing primary open angle glaucoma. It increases the uveoscleral outflow of the aqueous humor. And we have beta blockers like timolol, carbonic anhydrase inhibitors, miotics. All this decrease the production of the aqueous humor. And in laser surgery, we have laser trabeculoplasty or iridotomy. In laser trabeculoplasty, we make microscopic changes in the trabecular meshwork, and in iridotomy, we make a hole with the help of laser in the iris so that the aqueous humor can pass easily. And there is trabeculectomy, in which we make a hole, and there are different laser and surgical procedure like minimally invasive glaucoma surgery and glaucoma drainage implants. Since we have a basic idea of glaucoma, that types management, so we will move forward for the different case studies we have. Over here, we have a patient with name XYA, and patient is male, 56 years old, and the last day of checkup was 28th August 2025. The reason for visit was first eye check. They were having night glare, which means they have problem with night visions, and occasionally grow ache for the past 6 months. The history, they don't have any prior exams, no trauma or steroid use, and they are associated with a history of hypertension for the last 6 years, and they are taking medications. And the father had high pressure. They have no history of allergies, and they are non-smoker. This is the history of the patient XYA, and upon testing, we saw upon examination that visual acuity with pinhole was 6 by 6 in OD and 6 by 6 in OS. And after refraction, that patient had minus 1.25 diopter spherical in both the eye and plus 2.50 diopter spherical for near addition. And the pupil and extraocular muscles are normal, and there is no RFED. Upon slit lamp examination, we found that the patient's cornea is clear and the AC tip is quite deep, and the person has nuclear sclerosis stage 1 in early in both the eyes. And the IOP, when we measured with Coleman applanation tonometer at 3:30 a.m. in the morning, it was 26 mmHg in OD and 24 mmHg in OS. And the central corneal thickness was 520 micrometer in OD and 550 micrometer in OS. And upon gonioscopy, we saw they have a shafter 3 to 4 and TM trabecular meshwork seen 360-degree and no BAS OU. And in gonioscopy, this shafter 3AF means that the anterior chamber angles are wide open in both the eyes, and the trabecular meshwork and drainage angle is also open around the eye, and that person has no peripheral anterior syncape. And the optic disc ratio on OD was 0.7 vertical with inferior retinal thinning, and OS cup to disc ratio was 0.6 with rim intact. From this, we can get to know that the right eye is suspicious for glaucoma optic neuropathy since there is large cup 0.7 b, and usually the horizontal is greater than the vertical, but since this person has the vertical is a bit greater than the horizontal, so that person is suspected to glaucomatous changes. And in the left eye, the cup moderately enlarged 0.6, but rims are intact, so it's likely normal or early stage of glaucoma, and it needs monitoring. And macula or periphery are within normal limits in both the eyes. This is what we found upon examination for that patient. So the test baselines when we did an Humphrey visual test 24-2 on OD, there was a superior nasal step and there was a mean deviation of 3.2 dB. Mean deviation of 3.2 dB means there's a mild field loss. And since there is a superior nasal step, it is also an indication of early glaucomatous defect, and it correlates with the inferior rim thinning, which we saw in the earlier examination. And on OS, essentially full means that the visual field is within normal limit and there is no significant loss in that person's vision. And the OCT, the retinal nerve fiber layer and ganglion cell inner plexiform layer, upon OCT examination, we found in OD, the inferior thinning matches optic disc finding, the which one we just saw a bit earlier, inferior rib thinning, and it correlates with the VF superior nasal step. And on OS, borderline inferior, there is no definite thinning, but it needs monitoring as it could be a sign of early glaucomatous defect. And disc photos are taken so that there can be a baseline and a documentation of the person so that it can be used for future comparison and progression. And the first impression of was early primary open-angle glaucoma in OD. The fellow eye was glaucoma suspect. Thin cornea increases risk. And the management plan for the patient was to start latanoprost 0.005% drop once in both eye at night, and the target was to lower the IOP to less than 18 mmHg, as that person has more than 20 mmHg of IOP previously. And our main aim would be to teach them the drop technique and the punctal occlusion so that the drop can stay for maximum time in the eye. And for follow-up, we ask them to come 6 weeks for IOP checkup and tolerance, then 3 to 4 monthly if the IOP is stable. And then we will repeat the OCT plus the field test for every 6 months, then yearly or sooner if we see that there is any changes. And for the case study two, in case study two, we have a patient with name XYZ. She is a female, 54 years old, and the occupation is school teacher. The chief complaint were in right eye there was severe pain, redness, blurred vision, and colored halos around right for the past 10 to 12 hours, associated with nausea and headache. And in left eye, occasional blurring of vision and mild headache for the past few weeks. These were the chief complaint of that patient. And the history which we got from the patient is there is no trauma or ocular surgery, and family history was positive since her elder sister was diagnosed with open angle closure glaucoma, and the medical history was she was having hypertension for the last 2 years, which is being controlled under medication, and there is no history of diabetes. Allergies, she is not aware of allergies, and her prescribed glass power for reading was 2.25 diopters per equal. So upon examination, these were the things which we saw, that the visual acuity, best corrected visual acuity of the patient on right eye was 6 by 36 and on left eye was 6 by 12. IOP on affluation tonometer we found 47 mm Hg and 28 mm Hg. On slit lamp examination, we saw there were conjunctival congestion, corneal haze and shallow anterior chamber. And on left eye, it was quiet eye, shallow anterior chamber. The quiet eye means that there are no such defects. The cornea is normal. And in gonioscopy, we saw that the 360-degree is closed, and in left eye, it's occludable. And for the right eye, the pupil was mid-dilated and sluggishly reacting, and the left eye, the pupil was reactive. So the initial management was, since we can see that the person's IOP is too high and they have conjunctival congestion, and the with gonioscopy we saw that the 360-degree is closed, so it is an acute attack, and thus for the OD we are giving them mannitol 20% 250 ml stat, and it is an osmotic agent. It will draw fluid and it will lower IOP. And then we have oral acetazolamide 50 mg, and then 250 mg. It is a carbonic anhydrase inhibitor. It reduces aqueous humor production, and therefore topical therapy we have timolol 0.25 BD. Beta blockers decreases the aqueous humor production, and then we have pilocarpine 2% QID 4 times a day. It is a meiotic. It opens angle by pulling iris away from trabecular meshwork, and it will be used after the IOP is lowered. And then we also have prednisolone acetate 1% 4 times a day. And this steroid is used to reduce inflammation. And the main goal for this patient is to rapidly reduce the IOP and relieve the symptoms and pressure for definite treatment. And the definite treatment for this patient would be laser peripheral iridotomy, so that the aqueous humor can flow from the posterior chamber to the anterior chamber. And for the left eye, we have given them timolol 0.5%. Since the fellow eye is also at risk of acute attack, so we will also give them laser peripheral iridotomy as soon as possible. So the summary of this management would be that the patient has acute angle closure attack, and we are giving them both systemic and topical drugs to break the attack, and the management for them would be laser peripheral iridotomy after the IOP is controlled. And for the left eye, since there is primary angle closure suspect and that person is at higher risk of having angle closure glaucoma, so we will give them also laser peripheral iridotomy. And the investigations which we found on OCT was the retinal nerve fiber layer. In OD, there was superior and inferior thinning, which is one of the it it demon it is one of the signs that the person is having glaucoma. And in OS, there is superior thinning, and the visual field testing after stabilization. After stabilization means after the IOP has been reduced. We saw upon visual field testing that there was superior arcuate effect on OD, and there was early nasal step and OS. Both of them are indications of glaucoma, and that the person is having glaucoma. And the anterior segment OCT, we saw that in both eyes the angles were narrow. So what we did was we gave them for laser intervention for both eyes. They went laser peripheral iridotomy, and it was performed after the corneal edema was cleared. And upon follow-up visit that was done 1 week after the laser peripheral iridotomy, the visual acuity was 6 by 18 in OD, and the IOP was 19 HG. It got lowered, and the gonioscopy, the angles were open, and the fundus was stable with a cup disc ratio of 0.8. And in OS, visual acuity was 6/9. The IOP was also 16 HG. And upon gonioscopy, all the angles were open, and the fundus was stable with a cup disc ratio of 0.6. And the symptoms which the patient still had was pains and halo was resolved. Thus, we advised them to continue the timolol in both the eyes and taper the steroid in OD. And upon follow-up visit, which was done after 3 months post LPI, we saw that the visual acuity was 6/12 in OD, and the IOP was 17 HG. And OCT retinal nerve fiber layer, there was no further thinning. It was under control, and the visual field in OD, there was stable superior arcuate defect. And in OS, the visual acuity was 6/6, and the IOP also reduced 16 HG. OCT RNFL was stable, and visual defect in OS, there was no progression. Thus, we advise them to continue the timolol in both eyes and monitor every 3 to 4 months. And the patient was counseled like why they should adhere to the medications which are given to them, and how the disease has a chance of progressing, and what are the things which they and which we can do to prevent them for further diminishment of vision. And if the person faces any symptoms or any issues in the eyes, they have been asked to contact the doctor as soon as possible. And the final diagnosis for this patient was primary angle closure glaucoma, and the OD was in advanced stage, and the OS was in early stage. So, if we have the question, is glaucoma preventable? Then the answer is no. We can't prevent glaucoma, as its exact cause is not fully understood, and at the same time, we can't detect it from outside. But the progression can be slowed if we detect it early. These are not preventable because they are often asymptomatic in early stages, and late diagnosis, so already the loss is done, and damage to the optic nerve is irreversible. So, what will be our take home message? That we should go for regular eye checkups, especially if we are above 40 years of age or if we are at higher risk. If we have a family history of our parents or anyone having glaucoma, then we should go for early screening, and we should comply with the treatment to maintain the vision. Thank you.
Thank you so much, Gnanammal. We should really appreciate you for giving us an exhaustive presentation, both about glaucoma, everything we need to know about glaucoma, how to prevent all the signs, symptoms, and wonderful 2 case presentations you have shared. Thank you so much.
Thank you,
And
ma'am.
yeah, a really good job you have done. So let's all give a good round of applause for Gnanammal. So she has really, so whatever reactions you want to give, you can give in appreciation for what she has done. So good job. All right. So over to our moderator, Mr. Rahul. So we would like to hear some more clinical pearls from you. So I just called Mr. Rahul. So he'll be joining in 1 or 2 minutes. So meanwhile, any other doubts, any comments from you, any inputs you'd like to get from the speaker or the presenter, you can post it here. So I'm sure you also would have dealt with glaucoma patients. You would have seen those patients. So what I would suggest is every time you see a patient, please note down the details, because it will be useful for you for these case presentation sessions. And we're planning to have some case presentation competitions as well. So when you have these details properly documented, you can use it for the case presentation competitions also. There are also a lot of opportunities where you can publish interesting case presentations. So if anyone is interested in that, please contact me so we can mutually work on that, and those case presentations can be published as well. So meanwhile, Gnanammal, can you go back to your slide presentation?
Yes, ma'am.
So as she is getting her slide presentation, so you have all listened to her presentation. So can anyone tell me what are the field defects that is frequently seen in a patient with glaucoma? Okay, so I'm not going to ask her to show her presentation now. So don't go to that slide yet, Gnanammal. So just I would like the others. Very good. Yes, peripheral defects is right. But what type of defects do you see in glaucoma? Quickly. So on one hand, we have learnt a lot about glaucoma. So it will be good that if it stays in the mind of everyone. Yes, Ra. What are the field defects in glaucoma? Quickly.
Yes.
So you can
Now,
post it in the chat box. Yes, over to Mr. Rahul.
yeah. Now, am I audible clearly?
Yes, sir, you're
Now,
audible.
sorry for
No problem.
a good presentation has given by Miss Gnanammal. So thank you, Gnanammal, for giving us the information about the glaucoma, the basic of the glaucoma, and what is the importance, right? Because if we see, I want to say about the total prevalence rate or the scenario of the glaucoma right now. See, if we go through the Indian scenario that we have right now, more than about 10, 11 million people are estimated to have glaucoma within that range of 40 and older than 40. So the scenario, and we know as the second leading causes of irreversible blindness. So the importance is when we talk about that as an optometrist, what will be our responsibility to deal with the glaucoma and the such factors. And as whenever we talk about the glaucoma, yes, we'll go through the process. And firstly, what do we check? We check that IOP, right? That we go for that. Yes, there's a highest range of IOP or not, and we generally standard category. If we bracketing that range of IOP of normal or the standard is that 10 to 21. So now most of the time we get confused. Okay, yes, someone has came to your clinic or to your hospital. So as an optometrist, you have checked the you have gone through the whole history. And when you are taking the history, and after you are trying to check the IOP, you are getting that the IOP is coming 15 mmHg or the 16 mmHg at that particular time. So you might be thinking, okay, that it is coming under the normal, so there should not be any issue in the category of the optic nerve damage or in the category of peripheral defect, right now. But at that time, we should not forget the scenario, the reason of having the glaucomatous changes even after the IOP, the range of the IOP or the volume of the IOP is low, or that is coming under the normal category, normal range, because it comes under key if your IOP is coming under the normal range, even after that also that person could have the glaucomatous changes, because of we say that if there is any type of reduced blood flow, if there is anything related to any symptomatics or any systemic issues which is influencing the reduced blood flow to the ocular structure, so that time that could lead to the damage of the optic nerve and the peripheral defect. But it will not show you that or you will not get anything like IOP is getting high, or you will not get the IOPs coming more than 25 or 26, so that you can suspect okay, there could be a chance of any glaucomatous changes. So yes, that is the part that I'll suggest ki, definitely whenever we go for the assessment of a patient. So when we talk about while we are talking about the glaucoma, so definitely rather than the focusing on the IOP, only IOP, we should go for that angle closer, so that the angle, the anterior chamber angle. And if we have running out of time, okay, yes, I don't have time to go for the further checking, because I am the first person who is checking that particular patient right now, because as an optometrist, we are the first person who will go through the total history, and will take the visual acuity, will take the will check the refractive error and all. But yes, so we should not forget, if we are we have less time, so we can go through the list of confrontation test just to check ki there's any field defect or not, and you just go through IOP checking, so that you have 2 3 options, and depending on that 2 3 assessment, you can judge ki yes, there could be a chances of any glaucomatous changes or not, because right now you are not checking the posterior segment, you are not checking any type of assessment that will tell you okay, that posterior segment is not properly there. Okay, so these 2 3 things that we should follow, and the another one point that I will add, yes, we talk about that glaucoma, is it high blood pressures, the that will maybe that is associated with the intraocular pressure. But yes, the glaucoma, which is another reason which can influence to have heart attack, that cardiovascular disease. So we should not deal glaucoma patients, or we should follow, or we should spread some awareness ki the glaucoma patients, they should, like that Alina or that Gnanammal said in our PPT, that regular checkup. So that is why it is important. When a patient is having a glaucoma, this is that particular patient is having a long-term glaucoma history. So that patient should have a regular follow-up, because that glaucoma, which is another cause of heart diseases, that are heart attack. I think I couldn't recall the name of the authors or the researchers. I think the Korea and Taiwan, in that region, they have primary open angle glaucoma, which is a cause of ischemic heart attack. See, those are the studies. Those are the studies say, because they have gone through the glaucomatous changes, and which is actually connecting that influencing the heart diseases. So yes,
Probably you
definitely.
can share those research papers also. Probably there is some link between glaucoma and heart problem, probably.
Yes. I can, let me just
Okay,
open
then
that.
you can share it.
Yes. Right.
Sorry to interrupt. Yes, you can go ahead. You can share the link later afterwards.
Yes. Okay. Definitely, we'll have, if we get another
Yeah.
opportunity. Definitely, we'll discuss more about this glaucoma
Sure, sure.
and the other conditions of ocular structure.
Yeah.
Because yes, we are in that part of ocular structure. Okay, the patient that comes first to us, they don't go to that doctor firstly. They come to us first, because
Yes. So as
we
you rightly said, optoms are the first line of people who interact with the patients, and we can easily diagnose glaucoma. So optometrists' main forte should be in picking up the signs and diagnosing glaucoma when the patient comes itself. That's right. And even before the opthal sees the patient, we can check the IOP, we can do the gonioscope, we can do confrontation, and we can come to a tentative diagnosis. We can check the angle, whether it's open angle, angle closure, or whatever.
Yes. So this that responsibility, if we realize the power of an optometrist, so definitely we can yes, when we are seeing that this is a leading cause. See, there's a blindness, irreversible blindness. Because if
Exactly.
someone is having glaucoma, means there is no chance to get their vision, and just ask someone who is going through that process, who is going through that blindness, that ask them how to deal, how they do their daily task, what are the problems they are suffering daily basis. So as we have that sight, we have a good sight, so we are very much happy to, because we are able to see everything. Our visual function is working properly, but who have not that chance to see whatever around surrounding them. So for them it is, and when we have a chance to prevent, or when we have a chance to just understand that predetermination of glaucoma, and that we can stop the prevention or the progression of glaucoma, so definitely it will be good work for us also, that we are doing, so that a minimum prevention or the awareness that can help many to restore their, or not restore, but to, yes, to protect their sight.
Exactly. Yes. So thank you so much, sir, for giving your inputs, and thank you, Gnanammal, for your exhaustive presentation on glaucoma. And there's still lots more to discuss. So this time, so since we are time bound, we are going to complete the session now. But even more, about the visual fields, about the OCT, about their cup dysplasia. There's so much to talk
Yes,
and discuss about. And one thing about glaucoma is optometrists can fully do the evaluation, the diagnosis, the follow-up, everything can be done by the optoms except the surgery. And even when we see this patient where the patient has advanced field loss, so visual rehabilitation, low vision, all that also can be given by the optoms as well. So thank you so much for your presentation, and thank you for sharing your valuable inputs with us. And once again, a good round of applause for Gnanammal and Mr.
thank
Rahul.
you.
Yeah.
Yes, thank
So
you, thank you, thank you.
so I'd like to thank everyone who's joined us for this session as well. And a few announcements we have to make, like we have our conference coming up in the month of October. So this is a very unique conference where there is a collaboration between optometrists, ophthalmologists, and engineers. So you learn everything all about AI, VR, and so many things is covered here. And also, with the help of AI, early diagnosis of glaucoma is possible. The progression of glaucoma can be monitored. So many things are there. So there's a lot of things to learn from in this conference. This is coming up in the month of October 24 and 25. So even I would like to welcome you, Ms. Rahul, and your students also can join this conference. So this is a hybrid conference. So in Chennai, if you'd like to come, please register immediately because very limited seats are available. Online forum is also available. So we will send you the link and all the details. I think it'll be uploaded also along with our uploading of this case presentation as well. The links will be given in the description. So feel free to click the link and register. So apart from that, we at Dr. Agarwal's, we have our master's program also. A few more seats are available in master's. Nearly all the seats are filled up. If anyone would like to join the master's program, or if you would like to join the fellowship program, we have a 6 months and 1 year fellowship program. So you can feel free to contact us and you can join the sessions. And
Yes,
yeah. Okay then. So we would like to have a feedback from all of you, so you can give your reactions. How was the session? Do you have any doubts? Do you have anything to ask? You can post in the chat box or you can unmute. Okay then. So thank you so much for joining and see you all next month. So we will meet on the third Wednesday at 3 o'clock for the case presentation. Thank you.
yeah. Thank you, thank you, thank you, ma'am. Thank you for the opportunity.
Thank you.